Welcome to the session on clinical manifestation of tuberculosis. I am Dr. Purna Ganga Devi, scientist from National Institute for Research in TB. Now I am going to brief about the clinical manifestation of pulmonary TB and some common forms of extrapulmonary TB. TB primarily affects the lung, which constitutes 85% of total cases of TB, which we refer as pulmonary TB. It can also affect any other organ system in our body other than the lung, which we commonly refer as extrapulmonary TB. Extrapulmonary involvement can occur either in isolation or along with a pulmonary focus. Clinical manifestation can be either general or it can be organ specific. One should have a high index of suspicion in endemic setting while we are investigating for TB. The general symptoms of TB usually are unexplained fever of long duration, loss of weight, loss of appetite, night sweats, fatigue or tiredness, and in children a failure to try may be the only symptom for which they seek medical advice. Clinical manifestation of pulmonary TB includes chronic cough, which may be either productive or dry. It may usually lasting for more than 2 weeks. Blood in the sputum, which we refer as hemoptysis, chest pain, difficulty in breathing, dyspnea, and other systemic symptoms such as fever, weight loss, anorexia, and lassitude. This map refers to the percentage of extrapulmonary cases among the new and relapsed TB cases in the year 2016. Of the 6.3 million incident TB cases that were notified in 2016, extrapulmonary TB alone accounts for 15% of the total cases. The darker area in the map refers to places with a higher proportion of extrapulmonary cases, and the darker orange color represents areas with more than 30% of extrapulmonary cases being reported. This pie chart shows the distribution of extrapulmonary TB in HIV negative patients by anatomical site. From the chart we come to know that the most common form, the lymph node TB, accounts for 35% of all the cases, and the next common, pleural effusion, accounts for 20% of all the cases. The other common forms of extrapulmonary TB ranges from 3 to 10%. Lymph node TB is the commonest form of extrapulmonary TB. It primarily affects the children and young adults. It is more common in women, unlike the pulmonary TB, which is common in men. It affects both the superficial and deep lymph nodes. Superficial nodes, among the superficial lymph nodes, cervical lymph node is the most commonest one, which usually presents as either a single or multiple nodes, either on unilateral or bilateral. Deep lymph nodes are also involved, the most common site being the intrathoracic, abdominal, and retroperitoneal. It may be associated with systemic symptoms such as fever, weight loss, loss of appetite. Physical presentation depends on the stage of the lymph node TB. In stage 1, we can see enlarged, firm, mobile, discrete nodes showing non-specific reactive hyperplasia. When the nodes are large, rubbery, fixed to the surrounding tissue due to periodinitis, it refers to the stage 2. Later the lymph nodes show central softening resulting in abscess formation, proceeding to the cholesterol abscess and sinus tract formation. But the most common presentation in clinical practice includes painless, single or multiple, unilateral or bilateral enlarged peripheral nodes. The second commonest form of extrapulmonary TB is pleural effusion. It usually presents with cough, chest pain or shortness of breath with or without fever and weight loss. In empyema, where there is pleural collection of pus in the pleural space, there may be signs of toxemia in addition to the other symptoms, along with digital clubbing and intercostal tenderness. Pleural effusion usually present as an acute illness, and the symptoms usually last for few days to few weeks with symptoms of pleuritic chest pain, breathlessness, non-productive cough and fever. Occasionally the onset may be less acute with mild chest pain, low grade fever, cough, weight loss and anorexia. On physical examination, we can note down the shifting of the trachea. On percussion, we can have a dull note. On auscultation, the breath sounds are usually diminished. Meningitis and tuberculoma are the two common forms of central nervous system TB. TB meningitis is the most severe manifestation of extrapulmonary TB. Of all the cases of neurological TB, it accounts for 70 to 80% of the cases. The prognosis usually depends on the early diagnosis, and the most common clinical features include fever, headache, seizures or neck stiffness. TB meningitis is a disease of the childhood in developing countries, and in industrialized nations, people living with HIV account for more than 50% of cases of TB meningitis. The pathological features include inflammatory meningeal exudate, vasculitis, encephalitis, disturbance of the CSF circulation and absorption. British Medical Research Council had developed a method for staging the TB meningitis. The stage 1 describes the early non-specific signs and symptoms, which includes fever, headache, irritability and malaise, few or no clinical signs. Stage 2 describes the neurological disturbances without coma or delirium, but with few minor neurological deficit including drowsiness, lethargy, clinical signs of meningeal irritation, cranial nerve palsies, vomiting and seizures. Stage 3 describes an advanced stage with stupor or coma, often accompanied by paresis, hemiplegia or paraplegia, hypertension and postural changes. Long-term sequelae can occur in 40% of patients and death in almost 50% of patients in stage 3 condition. CNS tuberculoma is less common than meningitis. The usual clinical features depends on the anatomical location. Seizure is the most common presenting feature, and it may present with headache, fever or focal neurological deficit. One should be able to differentiate it from neurocysticercosis and neoplasm with the help of pathological and radiological findings. TB abdomen usually manifests as enteritis or peritonitis. TB enteritis is more common in the adolescents, and it is due to swallowing the infected sputum. Peritoneal TB results from the reactivation of a latent peritoneal focus or as part of a miliary spread. Peritoneal TB may occur in any one of the three forms, where the wet ascitic type is the most commonest one, with collection of free or loculated fluid in the abdomen, the dry type with adhesions, and the fixed fibrotic type where there is momental thickening. The most commonest site of TB abdomen occurs in the ileocecal region. The usual presenting symptom will be abdominal pain, which can be colicky due to the luminal compromise. If there is involvement of the mesenteric lymph nodes, the abdominal pain will be dull and continuous. There will be distension of the abdomen, which is referred as the Duffy abdomen. This occurs due to the mesenteric adhesions. When there is involvement of the ileocecal and small bowel, a mass can be palpable in the right lower quadrant, and there can be complication of obstruction, perforation or malabsorption in the presence of stricture. The TB abdomen also can present with constitutional symptoms such as fever, weight loss and fatigue. Let us look into some rare clinical presentation of TB abdomen. Esophageal TB presents with dysphagia, oligophagia and mid-esophageal ulcer. Gastroduodenal TB presents with dyspepsia and gastric outlet obstruction. When the patient complains of lower abdominal pain and passage of fresh blood in the stool, one should able to rule out colonic TB. Rectal and anal TB usually presents as strictures and perianal fistulae. Bone and joint TB, it accounts for 10% of all the extrapulmonary TB. Spinal TB is the commonest form. It occurs both in adults and children. The infection usually begins in the cancellous area of the vertebral body, where the vertebral body becomes soft and gets compressed, leading to wedging or collapse of the vertebrae. The exudate then penetrates the ligaments and follows the path of least resistance through the planes to distant sites from the original bony lesions where they form the cold abscess. Cold abscess can occur in retropharyngeal area, lumbar and in the psoas region. Usually the patient complains of localized back pain with tenderness of the spinous process, fever and weight loss. There may be signs of spinal cord compression also. Patients with advanced disease may have severe pain, spinal deformity such as gibbous, where there is flexion deformity at the most common in the lower thoracic and upper lumbar area, paraspinal muscle spasm or wasting and neurological deficit. In children, the presenting symptoms may be failure to thrive, night cries, inability to walk or cautious gait, use of hands to support the head or trunk. The earliest sign of spinal vertebral infection is backache. The constitutional symptoms such as weakness, loss of appetite and weight, evening rise of temperature and night sweats may also be present. When there is retropharyngeal abscess, the patient may complain of dysphagia, dyspnea or hoarseness of voice. There may be flexion deformity of the hip in case of psoas abscess, and the most serious complication of the TB spine is the Pott's paraplegia. Miliary TB is most common in immunocompromised individuals such as HIV patients. Usually there is multi-organ involvement. The visceral sites with rich vascular supply such as liver, spleen, bone marrow and brain are usually affected. The clinical symptoms may be subacute and non-specific. The chest symptoms can be obscured till late in the disease, and cough and dyspnea can be the only presenting complaint. Chest X-ray usually shows bilateral miliary pattern with multiple nodules of less than 2 mm size. It will be like this, and involvement of the eye can occur with choroidal tubercles, and neurological involvement may occur in widespread disease. Thank you all. With this we come to the end of the session 1 on clinical manifestation of TB and some common forms of extrapulmonary TB.